disappointing. Okay, haven't missed too much so far. So I will start resharing my screen. And hopefully you can see the slideshow version of that now. Okay. Great. So as I was saying, and just I won't go through this in detail, but it's just to kind of recap what we mean by trauma and what we mean by trauma-informed approaches. This is at least what was communicated to the different project partners that we funded. So again, I won't go through this in detail because I think it will take too much time to list it all off. And then this is kind of a very high-level logic model for the projects that were funded via the Better Mental Health Fund, and just outlining the different aspirations. So again, it's a lot of detail there, but just to point out that because they were so short-term, that realistically it was focused a lot around raising awareness about the topics and hopefully some increased confidence. But in reality, with the timeframes, although we did hope that residents might start to perceive that services are safe or trustworthy or collaborative, it was more likely that those would be kind of longer term outcomes of these initiatives continuing. So in terms of the training, some background to this, the aim was to train 2,000 staff across a wide range of sectors in the borough, so both the statutory or public sector as well as voluntary sector, providing an intro level training offer. And we did some initial stakeholder engagement to inform the planning with managers as well as practitioners, and a couple of workshops with local residents. And so on the screen are just some of the points that were made by local residents about barriers that they've experienced in relation to trauma-informed approaches not being used, and then some positive things that can help, that were kind of signals of trauma-informed approaches. And there was a lot of, I should acknowledge here that there was so much kind of helpful support and advice for informing the training content and the planning from ELFT, the Children and Culture Directorate, and others that had been doing this already prior to the funding from Public Health. So just a quick snapshot of the training delivery. The main training was the kind of 2 online modules that were delivered, that were each 2 hours. So understanding trauma was the module A, and then module B was implementing trauma-informed approaches. So like I mentioned, these were kind of very intro level, short, but the idea was to kind of get as many people as possible to be able to attend. And then a resource pack was also provided to each individual by email after the training. It was targeted towards frontline staff, although there were a small number of managers and people identifying as senior managers who also participated. There's a table on the bottom right that shows kind of a breakdown of attendees, although this, I have to admit that the data quality was kind of not always great in terms of people self-identifying as a certain sector when they maybe fit into multiple, so it's not so straightforward sometimes. But there was quite good representation across different health services, including ELFT and BARTS and GPs, social prescribing, community safety, including drugs and alcohol services, a small number of police towards the end when we finally managed to get a contact for them, small number from housing, relatively small numbers from children's services, as lots of these staff had taken previous training, so it wasn't promoted as widely to them. And just to mention as well, there was kind of a smaller delivery that was more so focused on children and young people and early years, called 5 to Thrive. I won't get much further into that. Going on to the next slide. So this is just some of the, I won't actually go into detail on this because we'll hear more from Darren. But there were some kind of pre and post survey questions that were asked to participants, which did show an improvement, I guess, across the training. So from before taking any of the training to taking one to taking both of the modules. Generally positive feedback, although some mixed depending on their level of, I guess, familiarity with the topic, and comments on the level of interaction having could have been better. And I'll skip the rest because I think we'll hear from Darren more so on that. With the service improvement pilots, a bit of background on this. So we engage with quite a range of existing local services to see who might be suitable to deliver this work, both in terms of like their interest and capacity to deliver the projects, because it is kind of it was a time commitment. We offered or prepared a service spec with guidance ranging from like explaining what trauma-informed approaches were, QI techniques or quality improvement techniques that we would be asking the projects to undertake, resources for involving people, and also different expectations and tools around monitoring and evaluation, which was a major kind of requirement from our funder. The project coordinators and lots of the staff participated in the training that was funded prior to their starting of the projects. And we also commissioned 2 facilitators with relevant expertise. So one of these was ELFT, Psychology in Hostels, and the other was Bromley by Bow Centre. And so ELFT mainly worked with one of the hostels, and Bromley by Bow Centre worked with the employment service that we commissioned. And then throughout the project period, we had monthly monitoring meetings with the coordinator and sometimes with other members of the team as well. So lots of here, which I won't go through. It just kind of highlights kind of the numbers of people that were directly involved in the projects across the different services, as well as people kind of indirectly involved. So these were kind of all of the service users or residents and all of the staff. So it wasn't that we had direct involvement from everyone. So just to kind of give a picture of what that looks like. I don't think I've already mentioned this. So we worked with 2 different hostels, Providence House, which provides support with people with kind of like longer term support needs, Founders House, which is a men's hostel, LBTH, Employment and Skills Services. So that's the service that's provided directly by the council. And then finally, the maternity service at Royal London. So different populations that where trauma-informed approaches are relevant. And then again, lots of detail at the bottom, but just to kind of highlight some of the change ideas that were generated following the initial kind of engagement period that each of the project teams undertook. So things like improving communication was a common one, including like digital communication and also kind of the language that was used, undertaking kind of further training on what is considered trauma-informed communication. There was some emphasis on changing kind of physical environments, whether it's in an assessment room or kind of the area where people would initially enter, as well as break spaces. Quite a big focus as well on improving or enhancing social connection and relationships, either between staff or between staff and residents / patients / clients. And a few other kind of more specific things. So well-being activities for both staff and clients / residents was also common. So not necessarily focused on relationship building, but just general well-being. These were things that were highlighted as valued. And then some more specific things, like in the maternity service, one thing that was highlighted that people felt to be traumatizing was if you're having kind of a more high risk pregnancy /birth, that it's quite traumatizing to be strapped down to the bed with the machine that they have to use. So one of their change ideas was to purchase a portable version of that so that the woman could walk around and be mobile during that time rather than being confined to the bed. So quite a range of things to implement. And like I mentioned, it's quite a short amount of time. So some of this was planned and maybe not delivered at the time of the project conclusion, but a lot of it's kind of continuing beyond the time when we concluded our contracts. And these are just some of the images or pictures from the projects, highlighting both kind of processes. So things like having an agreement of the project group. The bottom left, that's a driver diagram that was generated by one of the projects. In the top, that was one of the posters that was used to promote involvement by patients at Royal London, and then just some other images from the project change ideas. I don't think I should go into this in too much detail. Yeah, I might skip this part because we can go on to Darren's part of the presentation. So I'll stop sharing there. I hope that's useful background just in terms of what was implemented. And I will pass over to Darren, Dr. Darren Sharp.
Hi, Angela, Patricia, and everybody else. Good morning. Can you see the slide okay to begin with, Angela?
Yes, we can. I don't know if you want to put it in presentation mode. It's up to you.
I will do. Let me click it. Perfect. So that's better, isn't it? So thanks for inviting me to come along to, I guess, share some insights into the evaluation. And so just a bit of context setting, really. Who am I? So Dr. Sharp, sociologist. So my work is always around service improvements, really, and evaluations linked to service improvements in both health and social care. And so we was invited by Angela to evaluate this programme. And when I say we, it was myself and probably a team of 4 other colleagues. And so we was able to kind of, I don't know, form a multilingual, multiracial team to actually go out and talk to the providers, talk to a handful of residents, clients, stroke patients about their, I guess, exposure and experience of co-designing and co-delivering this piece of work. And so I've got a presentation. It's probably about 15 slides, but I just use that for really kind of back context. And I want to really share with you some of the key learning and some of the recommendations, what came out of our evaluation. And this is all focused, really, I should say. The caveat is about how do we then, what are our next steps in terms of embedding and creating a systems-wide approach to doing trauma-informed work across the borough. And so I'm going to kind of give you some insights, really, just to start stimulating this discussion and you're thinking about what next, in essence, in terms of embedding this type of approach. So if I move on to the first slide, and this kind of echoes what Angela mentioned earlier about the, I guess, our working definition of trauma. And so we started from the premises of Public Health England, who described trauma as severe psychological distress that someone experiences from a frightening or stressful event or series of events that has a long-term effect. Some examples include abuse, war and conflict, unexpected death, discrimination, bullying, as well as witnessing abuse or violence towards others, and intergenerational trauma. And of course, all this was against the context of COVID. And I believe the interventions were really kind of implemented at the back end of COVID. So it covered the last period of lockdown and going out, and the period when we were just coming out of lockdown. So it's really premised around the re-traumatization, potentially, what COVID it kind of caused on both staff and residents, actually, who took part in this programme. So if I just begin by just really talking about the rapid evidence review, what we did. So for any good piece of research, it's always important to know what we already know and what measures are out there in terms of what does a trauma-informed system look like? What is a trauma-informed borough in its full richness? So we looked at both peer review literature as well as grey literature. produced in the UK and elsewhere in the world, and we was able to kind of assemble a collection of fidelity factors or key principles what need to be considered. And I won't go through this entire list with you, but if I just pulled out a few just to give you a sense of what does good look like beyond Tower Hamlets. And so when it comes to the implementation, I've just pulled out three key fidelity factors or features. One element will be that it embraces the uniqueness of each service. So it's not that one approach, one method fits all. There's a recognition that it's about bringing together and drawing on the strengths and the uniqueness of the different services you're using, different methods, approaches, because they're engaging in people and supporting people in very different ways. A formulation of an hypothesis. And so, in other words, that leans very much onto the theory of change, what Angela showed earlier with the short, medium and long-term aims. The idea that you need a working framework, you need a vision of what good looks like. What is our final destination, or at least what are our kind of stopping points in order to measure our effectiveness in developing this type of intervention. And at this stage, clearly you've reached your short-term goals. Now it's about kind of reviewing and maturing the medium and long-term goals if they're still relevant. And then another element, what I just wanted to pull out, again, it echoes what Angela mentioned earlier. It's about, when it comes to trauma informed, it's about what are the skills, the knowledge and the language, and developing a vocabulary and a set of knowledge bases around what that means specifically to Tower Hamlets. Then if you look down in terms of a principle, so really we're talking about values and beliefs now. And so at the core of most trauma-informed approaches beyond the boundaries of Tower Hamlets, they emphasize that trustworthiness. And that goes again back to what Angela was saying about that relationship building between staff and staff, and staff and patients, staff and residents, and staff and the general public. So there needs to be it needs to be bolted in at the core of all these programs and initiatives, that sense of trustworthiness. Also role modeling. So it's not just about reading and communicating, it's like practicing what you're preaching almost. And another set of values, which I thought was important to emphasize, was about collaboration and choice. And at the core of all the pilots practiced in Tower Hamlets was this idea of co-production and co-design, people doing it together, as well as providing choice all the way along the journey. And then if we go into the other side and we just look very quickly at the learning, there were some key features what came out beyond Tower Hamlets about what are essential kind of learning components. And so one element, and which features very much in Tower Hamlets, which was actually a challenge, or an identified challenge post-training, was this idea of translating learning into practice. And so it's all very well being a co-creating knowledge and attending a training event, but the greatest need or the greatest challenge was, okay, how do I take this newly acquired knowledge and implement it in my workplace? And learners, as I will mention later on, identify that as a particular area of support as they go forward. Another dimension about learning was senior staff commitment. And so that may be about releasing staff to attend training, or equally about attending training alongside staff. Again, I would unpack that in a bit more later on. And finally, data usage. And that's my kind of, I guess, pet obsession about evidence-informed decision making. And so, although we're talking very much, when we're talking about trauma-informed ways of work, as a qualitative experience, what is key is also about collecting data and using data and bringing data into the training process in order to inform later decisions. And so that was a model or way of working which has been identified in the Peer and Gray literature as best practice, really, when it comes to creating a trauma-informed borough or a systems-wide trauma-informed approach. So we do know some of the kind of the building blocks behind creating a systems approach to doing trauma-informed work. Okay, so in terms of Tower Hamlets and their short-term goals, this is what my piece of work really focused on, and that was about increasing understanding of trauma and the impact of it on people's lives, as well as how to respond using trauma-informed approaches. And they correlate, of course, with the training and with the piloted sites, what was funded under this programme. In the medium-term goals, it was all focused around changing how organisations act. And then the long-term goals are focused around to improve access for people who would typically experience barriers. So you can see how they all incrementally build on one another, and they have an interdependent relationship. But as you know, it's far too early to actually report on medium or long-term goals. So therefore, the aim of this evaluation was to really, point one, is to see whether the programme achieved and implemented what it set out to achieve, and what was the gaps in implementation, and gather understanding about that. Also, the short-term aims was to gather kind of a range of perspectives, both the provider, the users, the trainers, etc., as well as the commissioner's perspective on achieving the short-term aims I've previously mentioned. And third, it's about teasing out learning for future action to becoming more trauma-informed as a borough in Tower Hamlets. And this is what my presentation is really focused on, point three, around what are the future actions. And also, I've got to mention at this point, if I forget, there is an evaluation report, what is sat with Angela. It's yet to be signed off for, but that provides more granular and more nuanced findings, really, if you're interested in learning more. So moving on slightly now, in terms of the evaluation itself, what did that look like? In total, we interviewed 66 participants, and like I mentioned, it was a range of people we interviewed. We interviewed some in semi-structured interviews. We also sent out practitioner reflection logs, which is more like a diary entry, and we received plenty of those. We also did surveys, and so we reached out to stakeholders as well as patients, clients, and members of the public as well. So what we was aiming for really is a multi-dimensional, you can say, perspectives on either accessing and participating in training or experiencing the pilot from multiple perspectives. All this was done in a very rapid way. So all these interviews really was conducted between May and June of this year. So I empathise with any of the pilot sites in terms of designing, running, and then collecting evidence on your pilot projects, because this is all being done at pace. And I guess that's one of the caveats behind the learning as well. What would this have looked like if we had like a 3-year run in and 3 years to actually do these pilots? It would be, I'm sure, very different. So moving on now, I just want to talk and start presenting some of the key learning, what we found. And already really, I'm going to echo a bit of what Angela said. So the first substantial kind of outcome or finding was the number of learners which was reached due to it being online. Traditionally, the providers wouldn't have normally ran this type of training online. It would normally be in person, face to face, therefore working with far smaller numbers. But I believe the target number was 2,000, and the program, due to it being online, was able to reach 1,800 directly. And so that was the method and the mode of delivery was effective and it worked. In terms of point 2, so training informed training plan was shortened, and so that was a compromise what was felt on the one of the main delivery partners side, in the sense that if this was delivered in normal times to a normal cohort of learners, this would have been kind of a 4-day long training program where they would have covered maybe more, or they would have gone into depth far more on specific components. However, due to the mode of delivery and the numbers what needed to be reached, the design of a program had to be reviewed and tweaked, which meant that they didn't cover the depth all the time they would have liked to have covered, or the scope. However, that was I guess, a compromise in order to fulfill the need for this particular program. The third point, sorry, what relates to training was an area what was identified by a number of the learners, and which I pertained to earlier actually. Yes, it was valued and of benefit attending the training in most cases. However, the real support and additional needs came into implementing the training. So there was an identified need for that experiential learning, where they're being guided and supported as they're implementing the actual knowledge what they've acquired. And so that's a gap going forward what potentially needs to fill. How do we better support people from training to actually test and start practicing what they're doing? The following insight was around theory versus practice, so theoretical models, and the danger was that the key principles, the values and beliefs, what I mentioned earlier, gets lost in understanding and getting oneself attuned to the different theoretical models, what we could align to theory of change, what was taught on the training. And so there was a bit of a disquiet or rebalancing what needs to be had when it comes to training, in order for the theoretical dimensions of learning about trauma-informed ways of working not to obscure and to blind the learners to the basic principles of doing trauma-informed working. So there's a bit of rebalancing, and maybe that had something to do with the program being edited down, but it's definitely something what needs to be considered for future training, what is planned in or across the borough. The final one is a point of learning was around participants who participated in the training, and Angela already identified that kind of the list of trainees, and how some individuals had multiple roles, so we can't really say healthcare that was an absolute figure. It's a bit more complex than that. But what we was able to kind of ascertain from feedback and the statistics is the low number of police officers what took part, although they did begin to join in increased numbers near the end. Why is that important? This is premised on a systems-wide approach to doing trauma-informed work. And so it takes every member, every officer, every actor in the system to actually have a shared understanding of this hypothesis. What is trauma-informed ways of working, and what are our collective action leading to a borough-wide understanding or delivery of a trauma-informed programme? So the police run their own training in-house, but how does that resemble the training you've experienced and your colleagues experienced? Linked to that, but separate from that, is the representation of senior managers on training, which again, some attended, but in significantly lower numbers than frontline workers. They were, I guess, frontline workers was delegated. It was delegated down to attend the training. However, in discussion with Angela, the commissioner, the invitation was predominantly targeted, I believe, at frontline workers. But the message from frontline workers, and again, this comes into the recommendations, they would have far more confidence in going back into the workplace, implementing new ways of doing trauma-informed work, with the confidence and knowledge that both they and their senior managers have a shared understanding and understand what resources are needed, what are the challenges, and just really the pace of doing this type of work. So it was all about having that reassurance for the frontline worker, having a senior manager on that training with them, or at least exposed to the training. So there was a definite gap in knowledge going upwards in this instance, what potentially can deter and skew behaviour on the ground. Okay, so the next learning was that the pilots projects needed to better consider the trauma in the staff before embarking on the pilot. So this is really linking to the pilot projects, that obviously this happened at the end of COVID and coming out of lockdown in relation to COVID. And it was very unstable foundations, very challenging and turbulent times in which this programme was being implemented. And we cannot take the staff and see them as abstract actors. A, the programme was focused on trauma as it relates to staff, as well as the general public and clients and patients. And B, we would all experience 36 months of a pandemic. Nonetheless, staff were still working in what they would consider very underpaid or low paid jobs. They were still dealing with the psychological, emotional challenges of dealing with COVID, as well as obviously providing a service. And so, although these pilots address these points, these are points what cannot actually be forgotten about or put to one side, and they have a direct relationship on the success of each of the pilots, really, and that is about understanding the staff trauma and recognizing that and accommodating that in terms of the design and the implementation of these pilots. That was crucial. The second part was around it goes back in terms of low pay and rent recovery as a specific example, in terms of the challenges that the staff needed to play. They had to play multiple roles when they went back to deliver these pilots. And if I use the hostels, for example, so at one side, they're dealing with implementing or enhancing their trauma-informed ways of working, being more compassionate, empathetic in their encounters with residents, but at the same time dealing with rent recovery. The kind of the eviction ban kind of ended as we was coming out of COVID. There was arrears what needed to be collected. So how do you deal with those internal and external pressures when you're trying to implement this type of program? So these were some of the dilemmas what the practitioners, people on the ground, was having to deal with in real time, really, which again impacted the actual piloted programs. Better targeted help, which is another learning element. Angela's identified that, yes, there were commissioned organisations what was put in place to support the delivery of the training as well as the pilots. I would go one step further and advocate for enhanced support or more targeted help for each of the unique services based upon the external and internal pressures, I've just kind of alluded to, and where we found the staff at that critical moment of coming out of COVID. So you cannot really underemphasize the importance of understanding the challenges and the opportunities as a pilot site or as an organization, and providing that right expert specialist support to ensure that all the areas to support the effective rollout of this type of program is there, and checking points at the very early stages. Finally, and I guess underscoring all those points and what I mentioned earlier, this piece of work was done at pace, and more time obviously would have been needed in terms of the development, implementation, and now the back end of the review. And so all this is done and considered through the lens of the rapid nature of this type of intervention. And these are the final set of learnings before we move on to the recommendations. The top one, in terms of challenges and opportunities in partnership working, this programme really exposed the ongoing challenges in terms of partnership working. And what comes to mind is really the challenges from the hostels in engaging and working with GPs when they're trying to advocate and promote the health and well-being of residents, as well as the housing, some of the statutory departments like the housing department. So these were key relationships where relationships didn't seem to change during the course of the pilot, and it still caused these external pressures and barriers in terms of how to effectively support people in a trauma-informed way. However, the flip side to it, COVID kind of tore down a lot of barriers. And so in terms of bringing in kind of expert health and social care support, that was seen to work. Breaking down interpersonal relationships, even between residents and workers, that was shown to be successful in certain sites. And so the pilots really shone a spotlight on what relationships work and where they work well, and what are the ongoing barriers in terms of relationships in order to move forward with this kind of trauma-informed way of working. A second or another learning was a measurement tool. So everybody who engaged in this programme was asked to complete the short Warwick and Edinburgh, and that was basically a tool decided upon by the funding body, the Better Mental Health Fund, for obvious reasons, so they can compare and contrast both internally progress made as well as across programs they funded. So it's a consistent measure they use. However, going back to the rapid time frame and the diversity in programs, what was used as part of this pilot program, it wasn't fit for purpose. As simple as that, really. It tells us some information, but it doesn't yield us credible information. And that, one practical reason, is the time sequencing. For the Warwick and Edinburgh, ideally you're doing it in 3-month intervals and following a person through that journey in terms of their exposure to the intervention. This programme didn't allow for those kind of time intervals to be kind of rigorously followed. Likewise, it requires individuals to willingly engage in doing those types of measurement tools. And when I say they, I mean the patient, the member of the public, or the client. So this tool wasn't fit for purpose, but nonetheless, a tool is needed in order to gather evidence, to make evidence-based decisions as you go forward. And so this will fall under one of the recommendations about using a recognised, validated tool or a co-design tool but one which is meaningful to Tower Hamlets and into your work, most importantly, in order for you to be capturing that information to allow you to tweak and refine and change what you do and how you do when it comes to trauma-informed work. Yeah, the pandemic served as both a driver and a barrier to this program, and I've really talked about that already in the different ways, and that's kind of self-evident, really. However, it's not, although it's a sentence I'm echoing, in reality, it's far more challenging to get a resident who has been isolating in their room for the last 20 months to all of a sudden come downstairs and be part of a co-production process. The co-production process, in essence, is part of the trauma-informed way of working, but getting them engaged to actually shape how that then progresses is what was asked for as part of this piece of work. But it was very challenging in order for all the pilots to consistently engage and work with residents based upon the experience, I've got to say, of the last 36 months. Yeah, so going back to supported multiple approaches, and so thank goodness that Angela, Patricia, everybody behind this program wasn't overly prescriptive in terms of what you have to do and how you have to do it as a pilot site. So what this program is able to demonstrate is a variety of trauma-informed ways of working with often the same client or the same family, actually, but serving different needs, that's actually looking at what matters to individuals and developing a trauma-informed approach, what is obviously contextualized within your service to meet those needs. And so that is what this program really shows, really, and that's all recorded in the main evaluation report. As a consequence, although we're talking about short-term aims, what you've done to date and what the programme is evident sets the seeds for developing a context-specific or a borough-wide specific trauma-informed ways of working, which is kind of Tower Hamletified, so to speak. Finally, a key area of learning is really, I guess this is like the challenge as opposed to learning, but now the funding has come to its end and this piece of work has come to its end in terms of being commissioned. How do we keep trauma-informed ways of working at the forefront of people's minds? And that can be both at the coalface or at the work floor level. That could apply to senior managers, but also to our organisations. So this is really where the recommendations start to kick in terms of how do we embed and create a legacy behind this piece of work. Before I go on, Angela, do you want to say anything about the key learning?
Not necessarily me, but I wondered, I've just pointed out in the chat that we do have two of the pilot project leads here today.
Yeah.
So maybe if they want to share anything or say anything at this point or after you're done.
Well, maybe at this point, actually, in case we kind of lose time or we go off point at all. So I don't know whether you wanted to reflect from the pilots what your, I guess, perspectives around the key learning, if you want to add any observations to that.
We have Julie and Mary. I don't know who wants to go first.
I don't mind. Julie, do you want to go first? I don't mind going.
No, it's fine, Mary. Go.
Okay, lovely, thanks. I have to admit, we really enjoyed the possibility of actually doing the pilots. And I absolutely agree with you. It was very time consuming and labour intensive. However, it did for us enable us to reach out to the residents, something we wanted to do, and we were just given another way of doing it. I have to say, having ELF work alongside us was fabulous because they brought in new tools. They opened doors for us for training that we wouldn't have had access to, like the QI leadership training, which was fabulous for 3 members of our staff that attended that. They introduced to us new models of working, like the PDSA, which I hear everybody that was involved in that pilot now talks about PDSA. That is not going to go away. That is PDSA, for people who don't know, is a Plan, Do, Study Act, and it's so simple, and it's something that's very easy for our residents to understand. And the change driver, we never had heard about change drivers, but it actually means that the meetings we do have are so much more meaningful. And I suppose, in summary, I mean, we did laugh because the C's seem to champion everything when it comes to trauma-informed working. To really support change, we felt consistency. So if you said you were going to do something, and absolutely right, staff have a multitude of different hats they have to wear, but it's also about the time commitment. So we were saying, even if no residents attend, they have to deliver the sessions because they have to be seen that we're committed to them. So there was consistency, commitment, communication, of which language, the number of meetings we had about the language that we use, and how our residents don't always interpret those words in the same way we might. So we actually found that, but we were very lucky. We worked with Che Roseworth, who works with Patricia, and we had Sarah O'Reilly. And what was brilliant is they came in and they were able to show the staff how to do some of these things. And then the staff were able to mimic that and follow that and continue that. So for me, what is lovely is what we started then is still happening today, and I don't see it going away. So I think that's really all, unless anybody has any questions on it.
No, and I think that's a fantastic testimony, Mary, in terms of the challenges and the successes, really. You know, but most importantly, how you overcame the challenges. Julie.
I mean, I echo some of what Mary says in terms of the time consumption. It was spearheaded by our head of service, and she attended a lot of the sessions. So for seeing her there was to help encourage the rest of the staff to get involved. We're still sort of working on some of our projects because they've been a bit slower. So we were changing the furniture in our office. The furniture only came last week, so we've just put that in. We had brought loads of different pictures and flowers and frames. So by the end of October, our space will be changed. So it's taken a while to get that space. But what we found with the co-production is you still need a member of staff leading it. You can't leave it to the residents or the that you're working with. So it was, I mean, for me, it was like taking on another job, like trying to spearhead everything. And even now we're trying, like, for me as the champion, I'm trying to understand, because I don't want it to be lost with the team, how we, like what we were saying about embedding it. So how we keep having those conversations. What does the CPD look like for the rest of the staff? Because I feel like it's starting, the furniture thing has made everyone think about it again, but unless we are regularly doing things and having these conversations, it sort of falls off again. So I find I'm having to keep pushing it and bringing it up consistently at SMT meetings that, you know, we've committed to becoming a trauma-informed service. So how do we keep working towards that? And I think what you said about the some support regarding the interventions, because we did feel really lost and out of our depth in the beginning. I think we were still trying to work out, what is it are we actually trying to achieve? And then it was like months down the line before it clicked. Which delayed us really understanding what we should have been doing in the early stages. But the staff trust element has worked really, really well for us. Like the things that were put on for the staff, they keep saying, what else is happening, what else are we going to be doing together? Like they had some really good events, and even the feedback from the trauma event we held for the residents was really, like, some of the residents, I've never had a massage before, I've never had this space. So that was really, really good to be able to do that for them. But I suppose it's still trying to get that engagement, and we're working on like continuing the participation with the residents, but again, due to capacity, I think we're gonna have to pick that up next year.
But thank you, Julie, for those observations, and so many points what you made, and Mary, actually really resonates in the sense that this is the beginning of a journey. And part of the problem, what we've been trying to square, and that's why I started off with a rapid evidence review. What does a good trauma-informed service or borough looks like? It's like tracing the Holy Grail. And I'm sure once we get there, you have to move on again because it will always continually change. That's human nature and human needs, really. And the second point, and I had a conversation with Angela about that, was about that learning about that targeted support. And I didn't want to unfairly kind of make a blanket statement and say everybody didn't get it or everybody did get it. But what we have identified, there was inequity in the system. And so the problem is, how do we work out and fix that at the beginning if we was to repeat this going forward?
And sorry, I was just going to add, it was just your point on the training, Darren, and yes, I think you're right. I think it was very much targeted at frontline. I think that was the way it came to us. But one of the things we very often find, if managers are on the same training as the staff, they don't usually speak, or they feel that they don't participate as well if managers are present. So I think a consideration perhaps is that there is a manager's training, because I personally think it's important that managers know what's happening on the training, to go on to your other point, that they're able to implement some of the things that came up in the training. But maybe that's something that maybe the first training should be for the managers of those services. And then the staff see that they have gone for the training too, and that then everybody is singing from the same hymn sheet when they come back to talk about what can be implemented and what might be needed, etc. It was just a thought when you were talking.
No, and that's a nice bridge actually into the recommendations now. So I'll pick up on that point, Mary. But thank you. So I'll just quickly pop up my slides again. And are you able to see that okay in its entirety? Perfect. So so based upon, I guess, those learning outcomes or challenges or successes, depending how you want to frame them, we've developed a number of recommendations, and these recommendations, I've got to say, lean more towards how the council can help facilitate, support the voluntary sector and work alongside other anchor institutions, really. But we aren't all exclusively for the council, obviously, to do and to deliver themselves, but they are, you can say, the matchmaker in many of these recommendations. So the first set really look at developing and delivering a strategic approach. And so the first recommendation is really for the lead anchor institutions, the council, to form a task and finish group to co-design and co-produce a borough-wide trauma-informed strategy. So that is really the eye-level big piece of work in terms of setting out over the next 5 or consecutive years, what does a trauma-informed a borough look like? What are we aiming to achieve? What services do they involve? And how do we tease it out in our commissioning and purchasing going forward to ensure that all our funded programmes are trauma informed? So that kind of strategic thinking needs to be done on the back of this work. Linked to that, the development of a business plan. or an action plan. So it's all good knowing what the vision is, but how do we actualize that vision? So some kind of action plan is needed to kind of go alongside that, along with a business case stroke action plan, what sets out a set of practices as well. And so that is more about what are the standards, what we expect, and what would kind of support a trauma-informed strategy across the borough. And that goes back from components, what I've mentioned earlier in the rapid review, to, okay, what does our training package look like in its entirety? Do we want training specifically for senior staff, frontline staff, as well as residents and patients and the general public? So the big piece, the first three, really cover the strategy, the business case, and developing a set of joint standards around the trauma-informed piece of work. Although they will exist on paper and express and communicate a shared vision, what that shared vision really is hoping to change is not just individual behaviour and attitudes, but it's about culture, organisational culture. Because fundamentally, this piece is all about the organisational culture. What we do, how we design systems, how we implement systems, and fundamentally how we engage and interact with the community we're all aiming to serve. And so it's a culture change, and any culture change takes time. It takes a multiple kind of approach in order to bring about culture change, and it also requires that top down as well as bottom up kind of buy-in and modelling in order to create that culture change. And so this recommendation is focused on that all these documentations and policies and procedures, what will be devised as part of that, would be underpinned and given life through that culture change. Also linked to that, the final recommendation is to provide the workforce with a step-by-step guidance on how to apply a trauma-informed ways of working. So that may be something very similar, Mary, to the handout what you was given. It may form part of the handout what was given by the learning training providers, but it could also form that missing information what Julie mentioned at the beginning of her pilot, where they just wasn't quite sure what they should be doing and how to do what they should be doing. And so what we do need for Tower Hamlets is some kind of a toolkit, a kind of guidance document. What could actually derive out of your pilots and out of this collective experience? So the assets are there. It's just about recording those assets in a way what would be useful for future projects, really, when they're considering implementing a program like this. The next set of recommendations now moves on and looks at embedding participation across our organisations. And so the first one is that the council should assist anchor institutions to further embed trauma-informed approaches in their core services by embracing the uniqueness of all organisations. So this is really a principle in the sense of meeting people where they're at. So it's about what approaches, theories to doing trauma-informed work complements their service, what they're commissioned to deliver. That's clearly the primary focus, be it on housing, be it on maternity care, and then teasing out the uniqueness and embracing their uniqueness to build a comprehensive programme or present a comprehensive overview of what trauma-informed ways of working looks like for the borough. Again, that should be embedded in some kind of toolkit and shared across the borough. Linked to that is also the council should ask other anchor institutions to gather and share data on related lived experience of trauma-informed experiences from both experienced by staff as well as the clients. And as part of this larger piece of work, start developing your own metric system. So how are you going to be measuring and capturing trauma based upon what you already know, but what you would want to enhance going forward? And how do you routinely and systematically collect this information? Only for two reasons: to know what you're doing, is it working? And if it's not working, how does it need to be advanced or enhanced and changed in order to make it work? And share your learning across the borough. So, yep, so to better monitor and refine find new ways to support staff experiencing trauma in the workplace, and how to better communicate trauma-informed practice values far more widely. So that's really just me repeating what I've said before, really. That's another advantage of designing a kind of framework what captures trauma-informed data. Finally, the implementation of a trauma-informed borough-wide strategy stroke business case should avoid overloading assigned coordinators and provide adequate services and practical support. So this goes to a point what both Julia and Mary both just mentioned, really, how coordinating this type of work, it can feel like another job. And without the kind of understanding and empathy from a senior manager and from other colleagues, you could be overburdened by this role. So in essence, it's about identifying the need for a coordinator, but also the need to properly resource and support that individual worker or team who are delivering these types of programs. It can't just be a tag on with no additional resources. Whoops. The next two recommendations look at how the council can better work with the voluntary sector in terms of developing a trauma-informed borough. So this really is about the council asking and working with the voluntary sector on ways to better support the voices of marginalised communities are heard at every stage. So I've talked a lot about a strategy, a plan, a business case, and resources, what sit behind it. The voices and the involvement of residents and patients should be involved in all stages of that co-development and co-design. And rather than the council reinventing platforms and mechanisms, they should be working with the voluntary sector, who are very closely working with these particular groups or marginalised groups, and some obviously public sector services as well. And so the VCS should lead on co-developing a mechanism in partnership with the council to ensure marginalised communities are empowered and supported to get involved in the co-production of a system-wide trauma-informed strategy, and with the emphasis there on co-production, what needs to be done. And so that's like a piece within itself, how to continually, consistently, and to an high quality engage the voices of the general public. The next set of recommendations really focus.
Sorry,
Yes.
I'm interrupting you, but I just want to flag up the time that the meeting is due to finish at 1:15.
Oh, at 1:15. Oh, okay, then. So I will wrap up very briefly. So, no, my apologies for that. I was thinking 1:30, but it's 1:15. So, final set. So one set is on key skills and learning, and so I've kind of touched upon that throughout the talk. But I think the key point was the training received was of benefit, but going forward, it's that training and support to bridge taking learning into the workplace. Also a focus on more specialised learning based upon your service and your knowledge of trauma-informed ways of working, with the addition of what Mary just mentioned, which is quite valid. It may be that training is organised for senior members of staff, which may be skewed slightly differently than frontline workers. But there's an entire piece on learning. And finally, there's also about training being more interactive and more smaller in size, what we seem to be more beneficial, that the learners have kind of come with those cultural competencies and kind of reflect the learner group as much as possible. I've talked about senior managers engaging, and these are just really emphasising the different levels what are needed, from foundational to advanced. And so I will stop there. All this and much more is contained in the evaluation report. So please, once it's signed off, please have a read.
Thank you, Darren, and I'm so sorry that we maybe miscommunicated timings. I think we could probably spend at least a day on the things that you've shared with us in a very brief space of time. And it's a fantastic piece of work. I think both the original commission and also the evaluation of it and the learning from it. And I think the challenge is I think everybody in this space knows that trauma-informed approaches isn't one thing that you do and then you've done it. It's an ongoing task that you have to keep supporting, keep tending, keep learning from. And I'm hoping that this space is one of the spaces that will continue to support that and support our organisations to share and learn. I don't want to keep people longer than we've scheduled, but just a quick flagging up for our next session is actually on the 4th of October. Now that might feel like it's come around quite quickly. Normally these happen every 6 weeks, but that's because we put back this session, we made it later. And that session is going to hear in a lot more detail about the work of psychologically informed environments in our hostels for homeless people, and Mary's already spoken a little bit about it, so we'll hear a lot more about the process and the learning. We wanted to test the water for some ideas that we've got going forward. I'm going to pause that and bring it back to the next session because I think we need a bit of time to discuss it. But I also would like to suggest that we schedule some space to digest and think a bit more about the learning and recommendations that are coming from this piece of work, to think about what we can do to support that once the report has been signed off and the council has responded. So that's something that I think we'll come back to. I don't think this is a done that action achieved. It's definitely a work in progress. So thank you very much, Darren and Angela, for presenting the work so far, and thank you for everybody joining us. I'm really sorry that we haven't had time for questions and discussions. There's been quite a active chat, which we'll kind of take into account, but we'll certainly come back to this going forward. So thank you all. I kept you for 2 minutes longer than I should have done. So I'll just say thank you and look forward to seeing you all in October.